Due to popular demand and to memorialize my most recent presentation to the AAPD, I have produced my Pediatric New Patient Exam lecture to view at your convenience. As always, please like and share if you enjoy this presentation, which has been organized into several parts: introduction, gathering of records, viewing of records, and dismissing the patient. It was 1977. Marquette University had just captured the NCAA title under Al McGuire. Graduating dental students sat in the Milwaukee arena waiting to get their diplomas, and the class awards would soon be conferred. What a surprise to be honored with the ASDFC award. So I did what any young graduate concerned with the cost of living would do. I accepted a prosthodontic residency at the VA hospital. At the time, I was stunned. Our pediatric education was limited, but I was honored, as I am today, to be able to share with you some of my thoughts and techniques that I utilize daily in treating the pediatric patient. Following graduation, I pursued prosthodontics, taught prosthodontics, and practiced it. I was approached by Dr. Charles Bowl, a dual-trained ortho and prosthodontist. I joined him in practice in what was Milwaukee's major adult orthodontic practice. It was after that brief practice in Milwaukee that I got married to Nancy and moved to Tucson, Arizona, and Scottsdale. I was asked to join Orthotown, where I was editorial director and published many articles. Finally, I saw the light and created what I believe was the Valley of the Sun's premier pediatric orthodontic practice, and it is my love of my newfound venture that motivates me today. But it's not about me. I'm here today to share with you the first of many techniques I have created and perfected to allow for a smooth operating combination practice of orthodontics and pediatric dentistry. I'm sure many of you have concern about referring, working, or partnering with an orthodontist. Some of you may have experienced some issues with this sort of relationship, like different techniques, technology, and of course, the talent. After my first article describing treatment timing, I had the opportunity to create an orthodontic pediatric dental practice with Dr. Robert Matthews, my partner. I have since written many articles that can be utilized in growing and perfecting the combination practice. I would like to share one of my latest articles, the Pediatric New Patient Exam. As a result of editing a trade magazine, I knew the trends in the industry were such that I needed to embrace CBCT and digital imaging. Our first purchase was a cone beam X-ray machine. This technology is the basis for our practice. It is a three-dimensional visualization of the face, bones, teeth, and soft tissue volumes, otherwise known as the airway. Starting with the face, the CBCT allows for gradual viewing of all of the structures from the outside to the inside. If you've had a root canal done lately, you know that even the endodontists are using cone beam to enhance the performance of their work. As far as radiation is concerned, those arguments have pretty much been put to rest with published studies and information by Ludlow. So after we installed the CBCT, we never looked back and continue to utilize the capabilities to improve on our treatment, but to educate patients, parents, and other professionals. We feel it's a practice builder and quite essential at this point with the added information gained and the ability to communicate with colleagues. So let's look at the workflow of a typical new patient exam utilizing digital photography, a cone beam X-ray machine, and in many situations, intraoral scanning. The advantages of performing the new patient exam in the conference room are numerous. It's away from the clinic, it minimizes anxiety, it's relaxed, there are props, siblings, and of course, marketing. The patient is seated in a roll-around chair for easy access and visualization, often while the parents finish the health history. The treatment coordinator takes the patient and performs digital records, including a cone beam X-ray, photos, and a scan. The advantage is that they are immediately available and can be checked for quality in real time. The patient is taken to the records area while the parent finishes the health history and can view some of the materials to be used in the examination. Photos are taken by the new patient coordinator. An intraoral scan is made in preparation for any appliances that may be prescribed. At this point, the clinical exam is performed by the doctor, who enters the room and focuses on the 4 elements of malocclusion as discussed in the Treatment by 12's article. If you look at everything that happens in orthodontics, diagnosis, treatment, retention, and even relapse, all can find origination in these 4 factors. Let's take a look at the jaws and teeth. The dentition is checked with the gum tissue and oral hygiene. The ventral surface of the tongue is evaluated for ties. An inexpensive disposable ruler is just as handy as a cotton roll, which is 36 millimeters, just the width as prescribed by McNamara. A chart on the wall allows for parents and kiddos to understand what I'm talking about and summarizes the jaw formation and the tooth eruption. TMJ health is assessed by opening and closing and watching for deviation and listening and palpating for sounds. We do a summary TMJ exam and ask to open and close and check for deviation and/or noises. Once again, I explain to the parent and patient what's going on. If there are noises, I explain the basic anatomy of the jaw joint. Lastly, I move to the soft tissue envelope, which is evaluated to check for oral habits and obvious signs of airway issues, such as adenoid facies. Next, I grab the lower lip and ask to swallow. A pull back on the lip indicates oral habits such as nail and lip biting, thumb sucking, and the like. At this point, I remind and show where the tongue should be at rest, and we practice together. We discuss how if the tongue and lips are working together, the teeth will stand up straight and the forces of biting will be vertical rather than angular, which can cause collapse of the bite and, of course, relapse. I turn to a photo binder to help explain how habits are so important in malocclusion. Probably the most underrated statement in the field of orthodontics was made in a 1907 textbook by Edward Angle, the founder of orthodontic practice. We now move to the computer monitor and review the photos and x-rays together. The photo and x-ray exam is done with the parent and child viewing the monitor on the wall. A typical set of 2-dimensional records includes the following 10 views. I generally pick a few to elaborate. Jaw structure and symmetry are identified on the patient, smile bones are identified, and the compensations of the teeth to the soft tissue influences. I explain the foot and shoe analogy. In addition to evaluating the jaw alignment, the panoramic film shows how the jaws are growing in the posterior of the mouth and potential conflicts in eruption of teeth, especially the cuspids. So much can be learned from the panoramic film, including how much growth potential is available in the molar area. An explanation is made that the most cosmetic incisor position is when the front teeth are upright and perpendicular to the floor. The molar position is also estimated. The 3-dimensional views are what really helps make decisions. One of the most significant views in the CBCT software is the sagittal, identifying tonsils, adenoids, tongue position, and lips. An airway screen is performed with 150 millimeters squared is the normal. The TMJ tab is evaluated. The volume view shows tooth positions and possible impactions. Returning to the section view, we highlight the width of the palate, the nasal cavity, and once again the tongue and airway space. At this point, we can visualize palate width, airway and tongue space, sinuses, and nasal cavity. The doctor summarizes based on the Treatment by 12's philosophy. The goal of this early treatment is getting teeth in position, proper width, and matching the smile bones to the jaw bones. We send the patient away with the parent with a brochure and a folder describing the various types of treatment that are offered and the type of treatment that may be indicated in this particular situation. Thank you.